Hey guys, they want me to chat a little bit about anticoagulation after stroke, ischemic stroke. Would that fair? Um, so ischemic strokes, first of all, if you look at the stroke CVA in general, uh, 10-15% of CVAs are bleeding, the rest 90, almost 90% ischemic. Bleeding is bad. Bleeding is bad. Blood in the brain is a really very, very bad thing, and most of the time the outcome is bad. Most of the time is hypertension, uncontrolled hypertension related. Obviously, some patients with Marfan syndrome or aneurysm, especially ladies, they may have just ruptured aneurysm and stuff like that. So that's another thing. But blood in the brain is always bad, especially if you're taking anticoagulation. Now, treatment of blood in the brain is just CV surgery, neurosurgery consultation, per holes, decreased pressure, and stuff like that, which probably you're not going to be involved ever. And in general, if you're bleeding in the brain, most of the time, because of vasoconstriction, you have to maintain blood pressure high. But again, that's another issue. The ischemic strokes, you can divide them to, probably 3/3. 1/3 is AFib, 1/3 is vascular, which is carotid, 1/3 is idiopathic. We really don't know where it's coming from. So if you're having ischemic stroke, and you don't identify atrial fibrillation, in that case, most of the time, what we recommend, we're going to name it as cryptogenic stroke, and loop recorder may be needed if somebody who's above the age of 60 to rule out silent atrial fibrillation. And in that case, the anticoagulation is the treatment of choice, which is either Coumadin or DOACs or something like that. In general, the strokes coming from the atrium, and I tell my patients always that the heart is a big blood vessel, and the strokes coming from the atrium, they tend to be big and in different distributions. All right, this is how neurologists, they come to you sometimes. Hey man, listen, I think this stroke is coming from the heart because it seems to be big. In that case, you really need to rule out atrial fibrillation, or if your patient is extremely sick and febrile, whatever, you have to rule out endocarditis in that case. So just remember that. The other third, which is vascular, i.e., if you see stroke or TIA, and you have stenosis in the carotid arteries more than 50. So if you have contralateral stroke, contralateral weakness, or ipsilateral visual changes, let's say you have right carotid artery, you have to have either left-sided weakness or changes in the vision on the right eye to say that this more than 50% stenosis in the carotid artery could be responsible. In that case, endarterectomy is needed, 50% or more. Okay. Now, if we're talking about 50% or more, I'm going to mention something that asymptomatic carotid artery stenosis, we usually send for surgery if it is above 70 or 80. But there's data confirming that asymptomatic carotid artery stenosis can be treated medically. Why? Because the stroke risk with endarterectomy is about 1 to 2%. Medical management is about 1 to 2%. So why you need to send your patient for intervention? So you really need to be careful about that, especially if you have elderly patients in the nursing home. So always remember these patients, if they are asymptomatic, and again, I'm sorry, also asymptomatic, meaning that they have not had a stroke over the last 6 months or so. Okay, so let's say I'm going to give you, because this is really a very complex issue. I'm going to give you a scenario. You have Mr. Smith. You do carotid artery ultrasound. There's 50 to 69% stenosis in the right carotid artery. and Mr. Smith has a little bit TIA 2010, that is considered asymptomatic. But if Mr. Smith, uh, you were consulted for visual changes last week, and you do carotid artery ultrasound, and you found 50 to 69% stenosis of the same on the same side where the visual changes happened. In that case, that's called symptomatic, and you have to send your patient for endarterectomy. If you do ultrasound and you find 80% or 70% or more, and Mr. Smith is 85 years of age, in that case, I wouldn't send him for surgical intervention or stenting. I would just treat it medically. And medically meaning good dose of statins such as Lipitor 80 or Crestor 40 and aspirin or Plavix. Okay. Now, let's say that your patient has ischemic stroke, and patient was in the hospital for 7 days, came from the hospital. There was diagnosis of atrial fibrillation. When can you start anticoagulation? You cannot start anticoagulation until you have clearance from neurology. Why? Because there's something called hemorrhagic transformation of the stroke, ischemic stroke, to bleed. And usually that take at least 2 weeks, and that is dependent on the magnitude of the stroke. If the stroke is big, okay, affects a huge side of the or big size of the brain. In that case, you really need to wait. Usually that what they do, they send for CT scan 2 weeks after the ischemic stroke, and if they don't find any minor bleed, in that case it's okay. If they find micro bleed, in that case is a very high risk of having bleeding, then anticoagulation will be contraindicated. Okay. Now, they did multiple clinical trials before about heparin in the case of ischemic stroke, and they found no benefit of using heparin in the case of ischemic stroke. So just FYI, we do not use heparin in the acute management of stroke. That's different from acute ischemic heart disease where you use heparin. So that's just keep that in your mind, FYI. But aspirin, Plavix, or uh, Berlenta are fair game. I'm going to mention this, that prasugrel or Effient is contraindicated in the case of ischemic stroke. It's actually black box warning, so be careful about that. Effient can't be used in the management of ischemic stroke, or if you have stenting and your patient has a history of ischemic stroke, is contraindication. Okay. Now, if you have ischemic stroke, carotid arteries are minor or a little bit mild, moderate disease, and you don't have any history of atrial fibrillation. You're not able to identify atrial fibrillation in that case. In that case, then the management is really aspirin. If your patient is on aspirin and they had stroke before, then you change to Plavix. If your patient de novo never had aspirin, then you do aspirin, and you do good dose of statin, which is 80 of Lipitor or 40 of Crestor. Anticoagulation would not be indicated in that case. Now, everything is DVT prophylaxis is fair game in any kind of stroke, even bleeding stroke. And I'm not talking about acutely. We were talking about, after 4 to 5 days after the bleeding stroke or hemorrhagic stroke, when you make sure that the size of the bleeding is stable. So DVT is fair game always. Always you need to DVT your patients if they're not mobile. Okay. So it's kind of sophisticated topic, but to summarize, if your patient had stroke in the setting of atrial fibrillation, you wait to start anticoagulation until you have a clearance by the neurology to make sure that there's really no hemorrhagic transformation, and keep that in your mind. If there's no hemorrhagic transformation, it's anticoagulation for the rest of their lives, or you do Watchman device or left atrial appendage occluder device. And the settings of carotid artery stenosis, symptomatic should be stroke, ipsilateral eye changes, or contralateral movement issues or sensory issues over the last 6 months. In that case, endarterectomy is needed if the stenosis is above 50% or more. Asymptomatic carotid artery stenosis, you have to be very careful. Actually, we sent lady to endarterectomy, and she had the endarterectomy done. She has about 80% stenosis, and 1 week later, she had stroke. So, you know, it's not really a very safe procedure. So just think about it. Any questions?
Is there a time if a patient has a CAD stent, carotid disease, is there a time when to stop statin therapy?
To stop statin therapy?
Yeah, because life care, they tend to discontinue all those statins for like older patients, 80 something years old, they discontinue all the statins.
No, there's actually new data about that. There's actually huge increase in MACE, which major acute adverse events, cardiac adverse events in the settings of no statin therapy if you're above the age of 80. So that's actually not standards of care.
Okay.
You know, as long as they can take the medication, they should be able to take the medication.
Okay.
So actually, it came out recently, about a year ago, that you cannot stop statin therapy because they found increase in the adverse events, cardiovascular and stroke wise in this kind of patient population.
Okay.
Any other questions, guys? All right. Okay. We'll see you in a couple of weeks.
All right. Thank you.
Thank
Bye.
you.